I think December 6th, people have some confusion about what's going to happen on December 6th.
That's okay. December 6th, we know what happened. So, okay.
We are live.
Yes, sir, we are live. Now we are start.
Can you start?
Yeah, Gansham sir, I'm starting, sir.
Please start, Mohan. Please start.
Yes, sir. Good morning, everyone. I'm Dr. Mohan Sai, final year DM resident at AIIMS Jodhpur. And before starting the discussion on target temperature management, I would like to thank Srinivas sir and Gansham sir for giving me this opportunity. So, presentation goes like this. And in the emergency department, we have a 40-year-old male who has collapsed in the park after a brief jogging. He received a bystander CPR for 15 minutes, and ROSC was achieved, and he was shifted to emergency department immediately. On arrival to emergency department, GCS was E2V2 M4. Patient was stabilized, ECG was done, and it revealed anterior MI. Thrombolysis was done, and ICU call was given for post-ROSC care. So I received the call, and after knowing the case, I called my ICU consultant to discuss regarding the case. And in return, my ICU consultant has asked few questions. So those questions include: how do you care for this case patient in the ICU? Do you want to provide TTM for him? If yes, how do you think hypothermia helps in this case? And if you are agreeing in providing TTM, what temperature you would choose and for what duration? Also, does it matter, like out of hospital cardiac arrest or in the hospital cardiac arrest? Does it matter? Or shockable, non-shockable rhythm at presentation? Does it matters? Now, I get a lot of questions, and for most of the questions, I don't have a clear-cut answer. So then I open my book, Textbook of Critical Care by J.L. Vincent. And in this chapter, I find what is target temperature management. And the book says, it includes the use of induced hypothermia followed by or combined with an active control of temperature after hypothermia over a defined period. So we have got two major components. One is we induce hypothermia. At the same time, it would be followed by active control of temperature. So what does this active control of temperature means? So it includes maintaining normothermia as well as avoidance of the fever. So now I switch to the guidelines, see if there is any recent guidelines, and I come across this ESICM guidelines on temperature control. What it says is, previously it is called as therapeutic hypothermia, then it is changed to targeted temperature management. But now they started to call it as temperature control. Now I was surprised, and what would be my reaction? I'm optimistic and I wanted to know more. So, before going into the research, what has happened, the trials which has happened, I wanted to know what exactly happens to the brain after cardiac arrest, during cardiac arrest, after cardiac arrest. So basically, we are looking at post cardiac arrest brain injury. So what happens is during cardiac arrest, there is a cessation of the cerebral blood flow. So as soon as the cerebral blood flow is down, oxygen goes down, ATP goes down, and that pushes sodium, potassium, ATPase pumps to go dysfunctional. Once they get dysfunctional, so the cell, the neuron invites a lot of sodium inside, water inside, leading to cytotoxic edema. Now, apart from influx of sodium and water, there is a potassium efflux. Now the polarity of the neuron changes and it leads to opening of voltage sensitive calcium channel. So that brings this calcium into the picture. Calcium gets inside the cell. Now, once calcium gets inside the cell, it doesn't sit quiet. Okay, it causes mitochondrial dysfunction. Along with that, there is a glutamate release into the extracellular space. Now, both of this causes additional problems. It will cause neuroexcitotoxicity. once a reperfusion is established. So now, apart from this, when reperfusion is established, there is also augmented production of free radicals, blood-brain barrier disruption. Now, once blood-brain barrier disrupts, a lot of inflammation comes inside the brain. So with all of this is happening, there is also dysfunction of cerebral microcirculation, where there is variable degrees of autoregulation, cerebral autoregulation failure, and microthrombosis happening. Now, ultimately, all of this damage that a brain sustains, it will push the neurons into programmed cell death or apoptosis. That's how post-cardiac arrest induced brain injury happens. Now, so we have seen that lot of process takes place in inducing the injury, but the most fearsome of it is a combination of cytotoxic edema, which happens due to cellular injury. A lot of sodium comes in, water comes in, and the calcium comes in. Along with that, there is a disruption of blood-brain barrier. It causes vasogenic edema. And because of autoregulation failure, there is a cerebral blood volume increase. So all of this would lead to intracranial hypertension, and this is one of the major comorbidities that patient will sustain after cardiac arrest, after ROSC, and we don't want it. So now, how does hypothermia helps? So previously it is thought that hypothermia, it will reduce the cerebral metabolism. It decreases 6 to 10% per degree of temperature drop below 37 degrees. So it is of perception that it only does this part. So it reduces the cerebral metabolism. But as a lot of physiological studies in animal models and all happened, then they realized that this hypothermia is an all-rounder. It not just decreases the cerebral metabolism, so it can stabilize the ion pump dysfunction, cell membranes, decrease the free radical production. It decreases the apoptosis. Apart from that, it reduces the vascular permeability. Also, it reduces the inflammation, and maybe it also reduces the suppression of epileptic activity and seizures, and overall it reduces a reperfusion injury. So now this hypothermia being a all-rounder, now people came to know that, okay, hypothermia acts at multiple levels and it prevents brain injury. So the first one to come up is Bernard's trial. In this trial, it happened in Australia, 2002, it got published. So they have selected out of hospital cardiac arrest who has sustained ventricular fibrillation after ROSC, if they're in persistent coma. So they were divided into two groups. So one group received 33 degrees centigrade for 12 hours, which was followed by 37 degrees centigrade for 24 hours, up to 24 hours. Now the group 2 had 37 degrees for 24 hours. Now the primary outcome they've seen is survival to hospital discharge with good neurological function to be sent home or to the rehabilitation center. And secondary outcomes are hemodynamics, biochemical, and hematological parameters. So there are a total of 77 patients, 43 in hypothermia, 34 in normothermia. We can see that in the hypothermia group, the primary outcome is much better than the normothermia group. Now, at the same time, another trial got published, and which is HACA trial. So similar to Bernard's trial, they have taken patients who are sustained out of hospital cardiac arrest and presenting with VF or pulseless VT. And after ROSC, there is no response to verbal commands. These set of patients, they were divided into two groups. So group 1 is 32 degrees to 34 degrees for 24 hours, whereas in group 2, they achieved normothermia. So the primary outcome they're looking is cerebral performance category 1 or 2 in 6 months. The secondary outcome they were looking at is overall mortality at 6 months, rate of complications in first 7 days after cardiac arrest. So again, we can see that compared to the Bernard's trial, they have recruited a bigger number of patients, at least 137 patients in normothermia and 136 patients in hypothermia. So as you can see, the percentage of patients in hypothermia who had a favorable neurological outcome is 55, whereas it is 39 in normothermia. The mortality is less in hypothermia group. It is 41% compared to 55% in the normothermia group. So these two trials were crucial in establishing that hypothermia is indeed helpful in patients who has achieved ROSC but have no response to verbal commands after ROSC. So with this, in 2005, AHA came up with the guidelines where it has introduced therapeutic hypothermia into the guidelines. So it says that unconscious adults with ROSC after out-of-hospital cardiac arrest should be cooled to 32 to 34 degrees for 12 to 24 hours when the initial rhythm was VF. Also, they've extended this guideline to non-VF arrest as well as for in-hospital cardiac arrest. So we got our first guidelines on therapeutic hypothermia in 2005. So after that, in 2013, we have got one major trial, so which we call it as a TTM trial, TTM1. So in TTM, again, they've seen, they wanted to see whether if we use a 33 degrees centigrade or if we use 36 degrees centigrade for targeted temperature management, is there any difference? So now again, they've taken the same population out of hospital cardiac arrest, but this time they've included patients with non-shockable rhythms as well. Now the criteria they've seeked is GCS less than 8. Now they've divided these set of patients, they're randomized into two groups, group 1 and group 2. Group 1, 33 degrees centigrade for 24 hours, followed by 37 degrees centigrade till 72 hours. And in the group 2, 36 degrees centigrade for 24 hours, followed by 37 degrees till 72 hours. So whatever temperature they wanted to test, they have tested it for 24 hours. And after that, they maintain normothermia for 72 hours, up to 72 hours, 37 degrees. The primary outcome here was a bit different. So they wanted to look at all-cause mortality through the end of the trial. In the secondary outcome, they wanted to look at a composite outcome of a poor neurological outcome or death at or around 180 days. Now, this trial, 33 degrees centigrade group and 36 degrees centigrade group, it didn't make much difference in terms of primary outcome and secondary outcome. So we can say that almost 50% of people in 33 degrees centigrade and 48 in 36 degrees centigrade had mortality. And neurological function, they've seen as cerebral performance category of 3 to 5, modified ranking scale score of 4 to 6. So almost similar numbers we get to see. So in TTM trial, we got to know that, whether it is 33 degrees centigrade or 36 degrees centigrade, there is not much difference. So again, in 2015, based on this trial, which has come in 2013, so they have changed recommendations to, we recommend the comatose adult patients with ROSC after cardiac arrest have targeted temperature management, which includes patients shockable rhythm, non-shockable rhythms, out of hospital cardiac arrest and in hospital cardiac arrest. So they recommended 32 to 36 degrees centigrade as the target temperature, and the target temperature should be maintained for at least 24 hours. Now, after 2015, a set of trials have come. So after 2015, the first major trial, which was TTM48 trial, where they wanted to see, giving hypothermia for 24 hours or giving hypothermia for 48 hours. So does it make any difference? So does increased duration of hypothermia makes any difference? Here, similar to TTM trial, they've taken out of hospital cardiac arrest. They've included all rhythms, shockable, non-shockable, and patients presenting with GCS less than 8. Now, they have randomized these participants into two groups. The group 1 is 33 degrees centigrade for 24 hours and group 2, 33 degrees for 48 hours. And the primary outcome, CPC score, cerebral performance category 1 or 2, which is good at 6 months. And secondary outcomes, 6-month mortality, incidence of adverse events, and ICU resource use. In this trial, 175 patients are in 48-hour groups, 176 patients are in 24-hour group. And here we can see that the CPC score of 1 or 2, which is our primary outcome, is similar, slightly more in the 48-hour group, but it is not statistically significant. And mortality is slightly less in the 48-hour group. Again, it's not statistically significant. Now they wanted to know if taking only non-shockable rhythm, asystole, pulseless electrical activity, how does hypothermia fare? How does targeted temperature management fare with non-shockable rhythm? Because previously, so far, whatever trials have happened, a lot of patients that they have included in the study, they have a major proportion of shockable rhythms in the group. So almost 3/4 of patients, you either everyone would have been shockable rhythm, or those trials which included non-shockable rhythms. So majority of them, at least 3/4 of the population, would be a shockable rhythm patients. So that's why now they wanted to see in the Hyperion trial whether how does targeted temperature management fare in terms of non-shockable rhythm. So now they have taken out of hospital or in hospital cardiac arrest. They have taken non-shockable rhythms, pulseless electrical activity or asystole, with a GCS less than 8, randomized into 2 groups, 33 degrees for 24 hours, followed by normothermia for 24 hours. Group 2, 36 degrees, 36.5 normothermia for 48 hours. Now, the primary outcome they want to look at is cerebral performance category 1 or 2, which is a good neurological outcome at 90 days. And the secondary outcome is a mortality. And here we can see that compared to the previous trials, the death by 90 days is very substantial, 231 and 247. And among survivors, the outcome, the good neurological outcome, the CPC score 1 or 2 on day 90, is also less compared to previous trials. It is 29 in hypothermia group, 17 in normothermia group. So, I mean, comparatively, hypothermia group fared well in terms of good neurological outcome. But if we see more data of this particular trial, majority of patients which they have recruited, the cause of arrest is asphyxia. So maybe the patients which they have received would have more severe brain injury, and in more severe brain injury, we were seeing a lot of mortality, and in the survivors, hypothermia has fared well. Now, based on this trial in 2020, we got again recommendations, nothing much new. So they say that TTM should be given for out of hospital cardiac arrest, in hospital cardiac arrest, any initial rhythm. Again, the same 32 to 36 degrees centigrade is the target for at least 24 hours. But now what has come new is that they are recommending us that we have to be actively preventing fever in comatose patients after TTM. So target hypothermia is okay, targeted temperature management is okay, but then after you rewarm the patients might go to have fever episodes, and that is determinal. So they are asking us to actively take care of fever in these set of patients. Now, again, once 2020 guidelines have come, another major trial which has come in 2021 is TTM2 trial. So now in this TTM2 trial, because in the previous TTM1 trial, they've seen that 33 and 36, it doesn't make much difference. So now they wanted to see whether a hypothermia versus normothermia makes any difference for out of hospital cardiac arrest. So now what they have done is, so they have selected patients of out of hospital cardiac arrest, any initial rhythm. So after ROIC, if they have a motor function on 4 score is less than 4, and no verbal response on pain, they have randomized these set of patients into group 1 and group 2. In group 1, so hypothermia was maintained for 28 hours and then rewarmed, and this temperature 37.5 degrees centigrade was maintained until 72 hours. Now in group 2, no intervention was made, and the group was observed to be maintaining temperature below 37.5 degrees centigrade for 72 hours. So in case if the subset of patients gets a febrile episode, so then they've instituted active fever reduction measures. So here in this primary outcome, they've seen all-cause mortality at 180 days and 180 days after randomization. Secondary outcome, proportion of patients with a poor functional outcome on MRS scale at 180 days after randomization. So what we can see here is it's a big trial, 930 patients in hypothermia, 931 in normothermia, and we can see that the primary outcome didn't differ in either of the groups. It is the same for the secondary outcome where the poor functional outcomes are similar in both the groups. And they also suggest that arrhythmias are bit more in the hypothermia group. So otherwise, it is now known that the hypothermia or normothermia, it doesn't matter after ROSC. So another 2 trials have come. So one is Capital Chill, a randomized control trial. Now they wanted to see if moderate hypothermia can be used or not in comatose patients after cardiac arrest. So they have taken out of hospital cardiac arrest. They've included all the rhythms, and for patients whose GCS is less than 8, they've randomized into group 1 and group 2. Group 1, moderate hypothermia for 24 hours, which is 31 degrees centigrade, followed by maintaining temperature for 48 hours, 37 degrees centigrade. In group 2, it is 34 degrees centigrade for 24 hours and 37 degrees centigrade for 48 hours. Now they are looking at all-cause mortality or poor neurological outcome at 180 days. And the secondary outcome, 19 parameters were assessed, including mortality at 180 days, as well as the length of the ICU stay. Now again, they have taken 184 patients in moderate hypothermia, 183 patients in the mild hypothermia. In this, the outcomes were similar. And even the mortality rate is similar in both the groups. So going more down in the temperature is not helpful. So now, the last trial which I'm going to discuss is HACA in hospital trial. They have taken only in-hospital cardiac arrest patients, any rhythm, GCS less than 8, randomized into 2 groups. Group 1, 32 to 34 degrees centigrade for 24 hours, maintain below 37.5 degrees centigrade till functional recovery. In group 2, normothermia and avoidance of fever till there is a functional recovery. Now, the primary outcome they've seen is all-cause mortality, and the secondary outcome is in-hospital mortality and favorable functional outcome. Now, again, we see that around 120 patients are randomized to hypothermia and 118 patients to normothermia, and the outcomes were similar in terms of primary endpoint and secondary endpoint. Now, after all these major trials in 2023, so there is an interim update about targeted temperature management. Now you can see the change in the wording. So they have taken it as temperature control. So now they recommend that all the adults who has achieved ROSC and who do not follow commands, irrespective of arrest location or presenting rhythm, they should have a deliberate strategy. They should be given a deliberate strategy for temperature control. And now they extend the temperature targets. So they say either you choose, any temperature target you choose between 32 degrees centigrade to 37.5 degrees centigrade. And now they say that we need to maintain this for at least 24 hours. And for this to be strictly doing it, we need to develop a hospital protocol. Now, they also say that when you're rewarming, you should not rewarm more than 0.5 degrees centigrade per hour. So apart from this, one crucial thing which we get to see is here, it may be reasonable to actively prevent fever. So again, they've emphasized that, the temperature control not just includes taking a temperature 32 to 37 degrees, 37.5 degrees centigrade for 24 hours, but it also includes prevention of fever. So now, apart from this, you get to see another thing where they say that there is insufficient evidence to recommend a specific therapeutic temperature for different subgroups of cardiac arrest patients. So now, because as the temperature target has become wide, 32 to 37.5 degrees centigrade, so who actually benefits from hypothermia, who actually benefits from normothermia, they are not able to give any recommendation on this. So the same with the 2025 guidelines. So they say that again, after ROC, if they're not following up verbal commands, irrespective of arrest location or presenting rhythm, you give a deliberate temperature control where 32 to 37.5 degrees centigrade is maintained. And what they say that the overall temperature control should be maintained for at least 36 hours. And again, same here in rewarming phase, it should not exceed more than 0.5 degrees centigrade per hour. Now, again, in 2025, they mention that they are not sure if hypothermia versus normothermia for any specific group, they were unable to recommend. Now we get to see that over in the last 15 minutes I've been talking about a lot of trials. I've talking about a lot of categories of patients out of hospital, in hospital, shockable rhythm, non-shockable rhythms. So that is how traditionally post-cardiac arrest brain injury patients were categorized. Now, what we need to understand is by categorizing these patients into traditional groups such as out of hospital cardiac arrest and in hospital cardiac arrest, shockable rhythms, non-shockable rhythms. So none of the trials, they were not able to prove the efficacy of hypothermia despite having a physiological rationale. So there comes, the factor of heterogeneity and phenotyping. So this narrative review comes, and one of the authors is Dr. Chiara Roba. So what the team suggests is that we need to possibly phenotype these set of patients, and maybe we need to look at anatomical basis of phenotyping, physiological basis, or electrographic basis of phenotyping. And if we do so, we'll be able to better understand which group deserves hypothermia or which group deserves normothermia. Now, taking this forward, so there was a nationwide multi-center prospective registry in Japan. And what they've seen is they have, moved away from the traditional measure of severities like, in hospital, out of hospital cardiac arrest. So they've used something called as revised post-cardiac arrest syndrome score. So RCAST score they've used, and, they've divided into low, moderate, and high RCAST scores. And they've seen whether TTM is helpful for them at either 33 to 34 degrees or 35 to 36 degrees. Now what they've appreciated is that, when the severity is high, RCAST score is high, severity is high, so it's not helpful. When the RCAST score is low, it is not helpful. The hypothermia 33 degrees to 34 degrees centigrade, we can see it in the blue bar. It's not helpful when the severity is low or when the severity is high. So it is helpful when the severity is moderate. So this is for the good neurological outcome. And it is also the same for the survival. So what we can see here is RCAST score low or high, it's not making much of difference. But when you see that TTM is given for the moderate severity, the survival as well as the good neurological outcomes fares better in the group which has received 33 to 34 degrees centigrade. So this is just one study. So again, another group of researchers, what they've seen is, can we use EEG and, we look at EEG patterns at 12 hours and 24 hours and divide the severity of encephalopathy into mild, moderate, and severe, and see whether, TTM at 33 degrees or 36 degrees makes any difference. Now, to say that it is mild encephalopathy, so continuous patterns at 12 hours. To say that it's moderate encephalopathy, so they have low voltage activity burst suppression without identical bursts, GPDs without suppressed background activity, and discontinuous rhythm. For severe encephalopathy, it is background suppression with or without bilateral synchronous activity at 12 hours or 24 hours. So that's how they divided encephalopathy into mild, moderate, and severe. And what they've observed is that for severe encephalopathy and mild encephalopathy, again, it's not making much difference. Whereas in the moderate encephalopathy, this 33-degree group is doing much better compared to the 36 degrees group. So in the moderate encephalopathy group, the 33 degrees centigrade hypothermia seems to be beneficial. Now, again, they moved from this out of hospital cardiac arrest, in hospital, all these things. And again, here what they've done is they've seen so they've seen again by looking at initial illness severity, and they wanted to look at 36 degrees or 33 degrees centigrade, which is more favorable. So here what they've done is, so they were looking at severe cerebral edema as well as highly malignant EEGs. And the illness severity is quantified by Pittsburgh cardiac arrest category. So Pittsburgh category, you can see that category 1, category 2 are good, whereas category 3 and category 4 are bad. So category 1 is awake, category 2 is coma with mild cardiopulmonary failure, 3 and 4 coma with severe cardiopulmonary failure, and 4 is deep coma. So this is Pittsburgh cardiac arrest category. So now they have taken this illness severity in the form of Pittsburgh cardiac arrest category, and they have looked at. So what they've done is, so first they've seen whether there is severe cerebral edema, highly malignant EEG patterns or not. So they've taken out the patients who have these kind of findings, and then they've given TTM at 36 to 33 degrees. So, and then what they found out is, so TTM at 33 degrees centigrade was associated with better survival than TTM at 36 degrees centigrade among patients with most severe post-cardiac arrest illness, but without severe cerebral edema or malignant EEG. So this study says that, if the illness severity is high, hypothermia is beneficial. So now should we look at it in this way that okay, in mild injury, no matter what you do, it's no matter in the sense, like if you give hypothermia or normothermia, it's not going to make much difference. So let us kind of be in a normothermia range. Whereas in moderate to severe neurological injury, we give 33 degrees centigrade hypothermia. We give this approach to based on neurological injury might be beneficial, but then we don't have current recommendations of dividing them into the groups and decide upon hypothermia or normothermia, and that's what makes this very much interesting. So now I think you guys have got a lot of confused, but we'll just quickly go through the process of hypothermia, how things are. So there are 3 phases of hypothermia treatment. So one is you induce, you maintain, and you rewarm. So there are 3 phases: induce, maintain, rewarm. So the goal of induction phase is to achieve the target temperature quickly. So if you decide to give a 33 degrees centigrade and you need to achieve this target quickly, we have 3 main categories of cooling techniques. So one is conventional cooling technique, where you use a ice pack or you use a cold saline, to bring on hypothermia. The better modalities are surface cooling techniques, which are blankets or surface pads. Now a modern technology has come where these surface pads are equipped with temperature regulation. Strict temperature regulation. Also, a much better one is intravascular cooling techniques, where there is a closed loop cooling as well as extracorporeal cooling. Now, which one to choose, it depends on the available resources you have. And although the current evidence says intravascular cooling technique is slightly better than surface cooling technique, but ultimately what matters is, if you get such kind of patients, you need to choose based on the available resources. So Fabio has given this nice table where you can see that surface cooling with temperature regulation and endovascular cooling. You can see that more or less they fare much better in terms of how much quickly they can induce, how they can maintain, and then how much workload does the nursing staff will have because of this TTM. So the problem with the induction is that as we start reducing the temperature, we get to see a lot of shivering, and the shivering can be divided into, the bedside shivering assessment scale 0, 1, 2, 3. 3 is more severe, 0 is none. So the shivering is a problem because, it counteracts the good, the goodwill we have. So it increases the cerebral metabolism, oxygen consumption, all of it gets increased. We don't want shivering. So because we don't want shivering, how do we avoid it? So, or manage it? So we manage it with paracetamol 650, RT6 Tarly, buspirone 30 mg RT-TDS, magnesium sulfate, acute cutaneous counterwarming, fentanyl, meperidine, opioids using opioids, dexmedetomidine, propofol, and intermittent doses of neuromuscular blockades. So now I must tell you that, in the induction phases, we can give a full boluses of these drugs. But then as we go to the maintenance phase, what happens is that when we maintain a 33 degrees centigrade, this hypothermia has, a systemic effect. So we have read that, in cerebral metabolism gets decreased, blood flow gets decreased. But then what we need to understand is it has systemic effects, and these are the systemic effects. So the most important thing is that it produces shivering. Then it has effect on heart rate. Heart rate gets decreased. Myocardial contractility increases. The sensitivity of myocardium to drug mechanical manipulation increases. Response to antiarrhythmic drugs gets decreased. Platelets decrease, drug clearance is decreased, bowel function is decreased, and insulin secretion and sensitivity decrease. So we get to see a lot of hyperglycemia. So now, keeping these systemic effects of mild hypothermia in mind, we need to understand that the analgesics which we give in maintenance phase needs to be more of boluses, which are timed to a greater duration. Like, the gap between two boluses should be great. It should be very big. And it's better to avoid infusions. But if you have to give infusions, it's better to give infusions at the lower doses, titrated to the effect. Now, once we induce the patient to a targeted temperature, it is important that we maintain that target temperature with minimal fluctuations. And if at all complications happen, say bleeding, hyperglycemia, arrhythmias and all, we need to manage those complications. Those are the goals of maintenance phase. Now, we need to continue analgesia and sedation. We need to target blood sugars 150 to 180 mg per deciliter because hyperglycemia is bad for the brain and also hypoglycemia. Now, what happens is that cold-induced diuresis happen, and not just fluids, a lot of electrolytes go out through the urine. So we get to see hypokalemia, hypomagnesemia, and hypophosphatemia. So we need to manage these electrolyte balances, maintain normovolemia, and more importantly, the other post-ROC care bundle needs to be followed. So we need to maintain saturation 90 to 98 degrees, 90 to 98%, PCO2 35 to 45 mmHg. All of this should be strictly maintained. Now, once we come to rewarming phase, say that after we spend 24 hours in the maintenance phase, so now we are going to rewarm the patient. The goal is to increase the body temperature at a rate not more than 0.5 degrees centigrade per hour. Now, at this point of time, we need to hold neuromuscular blocking agents, wean off sedatives to the lowest possible dose. And when we are increasing the temperature, we need to be aware of vasodilation and hyperkalemia. So after we are done with the rewarming, our job doesn't end here. So we need to understand that rebound fever might happen, and we need to take active measures to bring the temperature less than 37.5 degrees centigrade when rebound fever happens. So, we are going to end, by talking at some clinical scenarios, specific clinical scenarios. In all the trials which I have talked, pregnancy is a contraindication. So pregnancy was in exclusion criteria. But we have one scientific statement in 2015, which says that if used in pregnancy, targeted temperature management should follow the same current protocol for as for the non-pregnant patient. So pregnancy is thus not an absolute contraindication to targeted temperature management. So we often don't find discussion on pregnancy, whether we need to give TTM or not. Yes, we can give. It is similar to non-pregnant patients, and this is 2015 statement on cardiac arrest in pregnancy. So now we have got artificial intelligence and machine learning models. So in one of the study, they've used three machine learning models, which is generalized linear models, random forest, and gradient boosting. They found that generalized linear models, they performed best in predicting treatment effect associated with the target temperature management. So with almost ROC of 0.86 for prediction of survival, 0.85 for prediction of favorable neurological outcome. So now, I think AI and machine learning brings us more clarity as in which group deserves hypothermia and which group doesn't. They fare well with normothermia itself. So now suppose say that you have a patient who has received eCPR. What do you do with this? So this guideline has come in 2021 before the TTM2 trial. So that is why you get to see here that they advise 33 to 36 degrees centigrade for 24 hours, then gradual rewarming to 37 degrees centigrade for those patients who received eCPR and are on ECMO. So now, to finish this discussion, we'll just quickly go through the neurological conditions where the targeted temperature control is crucial. So my favorite traumatic brain injury has come. So you see CBIC guidelines have come in 2019. So in tier 0 and, in tier 3 of type B injuries, we get to see temperature discussion. So in tier 0, they say that you need to do temperature management to prevent fever and to treat core temperature above 38 degrees centigrade. So for all traumatic brain injury, severe traumatic brain injury patients, you need to kind of, treat core temperature if it goes above 38 degrees centigrade in tier 0. Whereas in type B, where ICP is elevated, in tier 3, when ICP is very high, you need to induce mild hypothermia, which is 35 to 36 degrees using active cooling measures. This is CBIC guidelines. Now, what happened is that in 2024, ASICM has come up with new target temperature control guidelines. So they say that in tier 0, you maintain, normothermia, and if it goes more than 38 degrees, you treat. So in tier 1 and tier 2, what they say that you maintain target core temperatures 36 degrees to 37.5 degrees centigrade actively. And in mild hypothermia, they suggest 35 to 36 degrees active temperature management. So this is a bit different from the CBIC, where tier 1 and tier 2 does not mention anything about the temperature. Whereas here, there is some addition of normothermia in tier 1 and tier 2. So neuroprotective therapy consensus review group has reviewed guidelines for intracerebral hemorrhage, subarachnoid hemorrhage, or acute ischemic stroke. In these patients, what they suggest is, so we should be maintaining temperature between 36 to 37.5 degrees centigrade. And when fever comes, within 1 hour of fever onset, we need to use active cooling measures to bring back the temperature less than 37.5 degrees centigrade. So to summarize, hypothermia has a physiological rationale. So in a set of patients who achieved ROC, whether to use normothermia or hypothermia, exciting future is ahead where we get a lot of studies based on severity. Already we got few, we'll get more. And machine learning is going to help us to understand more which set of patients will require normothermia or hypothermia. So for now, the guideline says 32 degrees centigrade to 37.5 degrees centigrade is what we need to target for at least 24 hours, and overall temperature for at least 36 hours. So by doing so, after this, we need to actively prevent fever, and so that makes temperature control more beneficial to the patients who have achieved RSC. Now, this temperature control is not just restricted to post-RSC acute brain injury, but also to certain other set of brain injuries like traumatic brain injury, ICH, SAH, and ischemic stroke, where you need to take care of the temperature. It should not go beyond 38 degrees centigrade. And if it goes, you need to bring it down. And, they say that 36 degrees to 37.5 degrees is good in neurological patients. But then when fever comes, within 1 hour, you need to bring down the fever. So I missed a lot of points to discuss, but then the teaching is only intended to create curiosity. I suggest all the trials should be read personally one by one and understand how things were done, and find out pros and cons of each trial. And with this, thank you so much for the opportunity.
Thank you, Mohan. I think we have reviewed everything related to targeted temperature monitoring and the principles and the logic. Unfortunately, like quite a few things in critical care, this is a sound physiological principle which is not evidence-backed at this point of time. An organ which thrives on oxygen, which is struggling to maintain its metabolic rate, if you slow down the metabolism, its demand should come down and it should actually improve. This is the physiological rationale. Unfortunately, we are not able to identify the correct cohort or the correct type of way the metabolic rate is reduced. When hypothermia was in vogue, we have used it very aggressively for our patients with excellent results. But again, now if you look at the results, it's not very surprising. But suffice to say that don't let pyrexia come into your neuro patient, whether it is stroke, whether it is trauma, whether it is subarachnoid, meningitis, non-convulsive status, whatever it is, euthermia is the bare minimum standard we should maintain. Selected cohort of patients, probably we can try to reduce the temperature to 35. Anything below that does not seem to be backed by the current body of evidence we have, whether it's the Eurotherm, what all other trials are the same. So that is the take-home point. Ghanshyam?
Nothing much from my side. I think you both have covered everything.
Okay. So if there are any questions or queries related to the talk, please do write to us and we will answer them at the earliest. And if you want all the articles which Sai has quoted, write to Sai directly, because he is the one go-to resource for all articles in the country. So thank you very much. Have a good day, and please join us again next week for another session on the Higgs platform. Thank you very much. Have a good day. Bye-bye.
Thank you, sir.
Thank you. Thank you, Sai.
Thank you, sir.
And all the best for your exam.
Thank you. Thank you so much, sir.